think we'll keep the discussion at the end of it, and I invite Dr. Cheriyan Mathew for the next talk. He will be talking about the algorithm in a case of vitreomacular interface disorders. He is a medical superintendent at Cheriyan Eye Hospital, Tiruvalla. He is an excellent VR surgeon as well as a cataract surgeon, which is a very rarity in the entire Kerala. So I welcome Dr. Shane.
So, good morning to all. I think there's a slight delay. Just an introduction on what I'm going to speak. I'm going to talk about vitreoretinal interface abnormalities. The word looks very large and huge and misleading, but it's nothing but problems between the vitreous and the retina, surface of the retina. This is a problem which we never used to really look into, because probably we did not have good investigative modalities to find them out. But with the advent of high definition OCTs, we are now able to pick up these subtle disorders, yet symptomatically or visually very challenging. And the good thing is there is effective treatment. I mean really effective treatment for it, and probably it is one of the areas where vitreoretinal surgeons like us are delighted to see the results. So, we'll have some more time on it now. Yeah, that's also surface, but that's a different surface. So, we'll go to the proper surface which I am going to deal with. Just come here. So, a patient with vitreoretinal interface abnormalities, how do he present to us or she present to us? So, the patient may have a subtle change. You look at the anterior segment, it's okay. You look at the fundus, more or less okay. But they say that, doctor, I definitely have a blurry vision, and it's of recent onset. Or the patient may complain of metamorphopsia. Rarely, even photopsia can be a symptom of vitreomacular interface abnormalities. The moment you see flashes, we think of a peripheral retinal break causing this, but even a vitreomacular interface abnormality can produce photopsia. Okay, so I think I'm good to go. So in the next few minutes, we'll be talking mostly about vitreomacular adhesions, vitreomacular tractions, macular holes, especially lamellar and full thickness macular hole, not forgetting epiretinal membranes. It is found in 1.5% of the population. So the magnitude of the problem is larger than what we think. And one of the important diagnostic tools is a simple Amsler's grid. This is going to tell you whether the patient has metamorphopsia or not. Multicolor imaging. It has come up in a big way in diagnosing vitreoretinal interface abnormalities, especially epiretinal membranes. In the presence of cataract, this will give you excellent images so that we can now know the margins of the membranes on what is happening beneath the retina. What is the status of the RP in the presence of an epiretinal membrane. So multicolor imaging is yet another good tool in assessing vitreoretinal interface abnormalities. By far, the most accurate method of diagnosing this condition is by doing an OCT, and it helps in following up, monitoring post-surgery and prognostication of these diseases. There are umpteen number of morphological alterations seen on OCT as described in the literature. Some of them are very valid, some of them is not so valid as well. Treatment, vitrectomy is the treatment of choice with 85 to 98% anatomical and functional success reported in the literature. Other treatment options include pneumatic vitreolysis and ochraplasmin. In the recent past, there has been a decline in the use of ochriplasmin, especially abroad. In India, we have not got it so far, but there was a decline. That's because of the toxicity of the drug as well as the suboptimal response following the treatment. So, by and large, vitrectomy is the treatment for these disorders. So, this is an OCT of a vitreomacular anomaly. So, how do we make a diagnosis? So, we have a vitreous attached to the fovea, but the anatomy and the integrity of the fovea is maintained. This is what is called a vitreomacular anomaly. So this patient, asymptomatic though, we saw something slightly whitish here, took an OCT, and this is what we saw. So this is an asymptomatic patient with a vitreomacular traction. So we name it vitreomacular traction because there is an anterior retinal change. So you see a traction with a retinal change, you call it a vitreomacular traction. And this is called a pseudo hole. The patient is asymptomatic, so we just keep observing. We give them a home Amsler's grid, patient goes home, check for any changes, and if there is worsening of symptoms, we definitely consider treatment. So here is a patient with So here is a patient with vitreomacular traction, and the patient is mildly symptomatic. Even in mildly symptomatic cases, here we have only anterior retinal changes. You tend to observe, but observe very closely. If the patient's VMT increases or a posterior segment changes happens, you need to treat it immediately. But sure and certain, within a 1 month's time, there is a spontaneous release of this VMT. So there is a chance that 30% of the cases may have a spontaneous release. But there is also a chance that 70% of the patient, if the VMT does not release, will have visual deficiency. So that is what I'm going to highlight in the next of my talk, in the few minutes of my talk. Epiretinal membranes, they are fibrous proliferations on the surface of the retina or to the posterior hyaloid phase. This is a slide to show you the importance of operating an epiretinal membrane early. On the left hand side, we have an early epiretinal membrane with good visual acuity, but the patient was mildly symptomatic, mild metamorphopsia. We did surgery, the patient got back 6/6 vision with a good anatomical contour of the fovea. Here is another case where we waited for the vision to drop to 6/60. This was the older concept. We were taught that the visual acuity has to reduce beyond 6/18 or 6/24 to consider surgery. See what has happened. We have done a good surgery, removed the epiretinal membrane, but the BCVA is only 6/18. There was an improvement though, but it has not come back to 6/6 or 6/9. That is because of the irreversible damage of the inner retinal layers seen on OCT. So the message or the take home is operate epiretinal membranes early and don't wait for it to drop down if the patient is symptomatic. So when do we not consider surgery or when do we delay surgery? There are few instances when we have vitreomacular anomaly with advanced glaucoma. Already the RNFL is damaged, the retina is thin. Any trauma to that may exemplify the visual loss. So this is a patient where we are not very keen on operating these patients. Yet another area is where there is a lot of RP damage at the macular area. The visually may not benefit. So these situations we may hold on for surgery. Especially a macular hole with mactal or a foveal atrophy. These are situations, or a patient with macular hole and macular ischemia, we do not operate because we know that the functionality will be very less following surgery. But in rest all cases, surgery is the treatment of choice. There are certain not so good or bad prognostic signs following vitreomacular interface abnormalities, like patient has a vitreopapillary traction, a cystoid macular edema, tractional detachment, a macular schisis, or a broad-based vitreomacular traction, an epiretinal membrane along with the broad-based traction are all negative correlates to good visual acuity. Govito et al. Classified epiretinal membrane into 4 stages. So the 4th stage, you can see there is a complete disorganization of the inner retinal layers, whereas in the 2nd and the 3rd stage you don't have. So try to operate the patient when they belong to the 2nd and 3rd stage and don't delay it to the 4th stage because you may have irreparable damage. Better prognostic biomarkers in OCTs are a good shorter duration of symptoms, a V-shaped or a focal VMT, a thinner preoperative central macular thickness, and a postoperative restoration of the inner and outer retinal layers. So coming to the macular hole, we all know, well, initially the first group who published results of macular hole showed a success rate of 30%. 3 years later, the same group published with a success rate of macular hole as 70%. Now, years down the lane, we boast about a success rate for 95 to 96% of most of the cases, at least anatomically. So, just take one more minute, please, Rahul. So, this is a case of a relatively large macular hole which underwent vitrectomy. It's around 1000 micron size hole. There was a good anatomical reconstruction. We did an internal limiting membrane peeling and a bridging flap. You can see that the internal limiting membrane flap bridging the hole. So now the concept about macular hole surgery, we do internal limiting membrane peeling in almost all cases, and larger macular holes, we bridge the gap of the hole with internal limiting membrane to facilitate closure and better anatomical integrity. So the current practice is that, and here is yet another patient. She came to me with the complaints of defective near vision since 1 week. This is to exemplify what I discussed at the beginning of the talk. The right eye showed a macular hole, everybody knows, and the left eye shows a vitreomacular traction. So the point is, which eye do we operate first? I operated the left eye. The vision is good, but my point is, this is what the patient came from. She had a recent drop in vision in near vision. It is not because of this bigger macular hole. She would have had less vision in this eye since a long time. So I operated the left eye. This is 2 years down OCT, 6/6 vision with a normal foveal contour. Operate these eyes, especially the ones with the other eye macular holes. Even in early VMT, you need to consider surgery because definitely that's going to give good visual acuity. The other eye also we operated, had a type 1 closure of the macular hole, but the vision is only 6/36. So that is my take home message. A lot of OCT biomarkers like the minimum linear distance, the basal linear distance, and also the whole edge height configuration, a lot of indexes on OCTs which telling us an idea about which hole will close, which hole will have improvement in vision. So there are 3 classifications available for vitreomacular interface abnormalities. Everybody knows this is the GAS classification, this is the International Vitreomacular Traction Society classification, and this is the closed study group classification. I would like to highlight this point once again. The smaller holes we used to do macular hole surgeries, but recently the closed group evaluated larger holes. So they divided holes again into large hole, an extra large hole, double X large hole, and a giant hole. So virtually now we operate on any macular holes. So this is an algorithm for managing vitreomacular interface abnormalities in a nutshell. VMA or just an anomaly you observe. There is vitreomacular traction, the patient is asymptomatic, again you observe but have a close watch. Vitreomacular traction with symptoms, mostly we prefer doing surgery. And macular holes, with or without VMT, with or without ERM, the treatment is surgery. So this is the surgical results of large macular holes, and the study clearly showed that when you use something to stuff the macular hole, definitely the success rate improves. Especially ILMs, macular hydrodissection, human amniotic membrane transplantation, or even an autologous retinal transplantation, all has improved the success rate of large macular hole surgeries. So again, the algorithm for treating a macular hole, oh well, this is a large, look at the size of the macular hole, it's almost 2000 micron. There is a lot of RP damages. Normally we don't take up this case for surgery because the prognosis is not so good. But in the presence of a retinal detachment, we decided to operate this patient because otherwise the patient may land up having a total retinal detachment. And had a successful closure of the macular hole, we did ILM stuffing into the hole. So this is a case of a lamellar hole associated epiretinal proliferation. We did excise this, but not to have much of visual benefit. So the take-home message is identify the entity early. Early treatment is the rule. OCT is the investigation of choice, and we have good results if taken up early in the course of the disease. Thank you.
Thank you, sir.